everyone, I'm Dr. Sarah Lynch. I'm a clinical assistant professor at Binghamton University School of Pharmacy. This presentation is going to introduce the topic of pharmacist-prescribed hormonal contraceptives. This is an emerging area of pharmacy in certain states, and we will take the time today to discuss some of the legislative changes, as well as the differences in prescribing compared to the more traditional role of a dispensing community pharmacist. Here are the objectives of this presentation today. I'll let you review those. Now, before we get into pharmacist prescribing, I want to do a short review and overview of contraceptive products. Birth control comes in a variety of forms with a wide range of efficacy. Options range from fertility awareness and withdrawal to condoms and other barrier methods, to hormonal contraceptive options such as the pill, patch, vaginal ring, and depot shot, all the way to sterilization, implants, and intrauterine devices. Patient choice depends on personal preference, desire for efficacy, tolerability, and safety. This chart represents the popularity of different birth control methods, with birth control pills representing the largest reported category of use. We're going to be discussing hormonal contraceptive options today, including the pill, patch, ring, and shot, but keep these variety of methods in mind. When helping patients choose the perfect product, a non-hormonal method may actually be the most appropriate choice for that patient. Intrauterine devices are a form of long-acting reversible contraception and are increasing in popularity due to their ease of use, tolerability, and efficacy, but again, that's something pharmacists themselves can't administer. The American Congress of Obstetricians and Gynecologists, or ACOG, has identified 6 main barriers to contraception use. The first is awareness and education, both the importance of contraception, how to use it appropriately and effectively, and also where to access it. In some areas of the United States, the nearest doctor's office or women's health center may be miles away. Individuals may not know where to go, and even if they do, they might not have reliable transportation, or they may not be able to get an appointment for several months because the area is underserved and the doctor has a patient waiting list. There's also the cost to consider. A doctor's appointment may be too expensive for an individual without insurance or a high deductible plan. The patient may also fear that the product itself will be too expensive for them to afford. If an individual does not have any other health concerns, they may choose to not bother with the appointment and forego the most effective or even any contraception option. Another barrier to access is the general practice of using contraceptive seeking appointments for annual physical exams and cancer screenings. It makes sense. Patients don't need to return for multiple visits to get their recommended screenings. And some of the exams for breast, cervical, and ovarian cancer can be pretty invasive, so doctors may think that linking the appointments to contraceptive refills will keep women attending their appointments. However, these screenings are not necessary to safely prescribe contraceptives. And it's been shown that even in women who choose contraceptive methods that do not require a prescription, such as condoms or the rhythm method, they will still visit the doctor for their annual screening. Which brings us to regulatory environment. And this is where we'll focus on for much of the rest of the presentation. Who can prescribe? If the medical procedures aren't necessary to safe prescribing, why is it limited to physicians, PAs, and nurse practitioners right now? Finally, some individuals object to contraception. There's a choice that an individual gets to make for themselves. However, it's important that healthcare providers are able to clear up misconceptions and are available to answer questions. Contraceptive choices are quite varied, so while one option may not be appropriate based on history or beliefs, another option may work quite well. So what role do pharmacists have in providing contraceptive care? In traditional dispensing roles, we have provided medication counseling, have answered questions, and made recommendations. However, we're starting to see that some states are shifting towards giving the pharmacist a larger role in contraceptive product choice. As I stated on the previous slide, in order to safely prescribe any form of self-administered hormonal contraceptive, a physical exam is not necessary. Only a blood pressure and medical history is required. Pharmacists can carry out both these tasks, and pharmacists are educated in medication safety and choice, which is why some states are using pharmacists to bridge the gap in increasing access, especially to underserved populations. I want to do a quick review of some terminology we'll come across today. Dispense is what we typically refer to the role of the community pharmacist. When I refer to it here, it will include the process of reviewing whether a prescription is appropriate, filling the prescription, and then counseling the patient on the product. Prescribe and furnish are used in a similar context in some of the laws we review today. There seems to be little difference in the meaning. If you were to read the laws as they are written on the books, Oregon uses prescribe to explain what the pharmacist does, while California uses furnish. Collaborative practice agreements are an agreement between a physician or other allowed provider and a pharmacist. These individuals work together to develop a protocol that the pharmacist may follow to make patient care decisions. This can be described as dependent prescribing. The benefit of this is that it can be very flexible. The downside is that it requires a pharmacist to find a prescriber and develop a professional relationship in order to care for patients together, which can take time and effort. State protocols refer to laws that grant all pharmacists meeting certain criteria that ability to perform a task. The state may also require that a certain process or protocol is followed by those who meet the criteria and want to do that activity. Over-the-counter medications are available for purchase with no limitations. Examples include products like vitamins, ibuprofen, set of laxatives, and many others. Behind-the-counter medications are deemed such because they have some sort of double check that the pharmacist must look at. One example is pseudoephedrine products in many states. The Combat Methamphetamine Act of 2005 put limits on the amount of pseudoephedrine and ephedrine purchased over the counter. Individuals must come to the pharmacy counter, and many states have a database to track these sales. Now we're going to move into some of the specific recent regulatory changes in the area of pharmacist-prescribed contraceptives. One of the first places we saw pharmacists initiating hormonal contraceptives was in Washington state. Pharmacists have been entering collaborative practice agreements with physicians in this state to prescribe hormonal contraceptives since 1979. This is considered dependently prescribing. In 2003, a study known as the Direct Access Study took place to assess pharmacist-prescribed hormonal contraceptives. When the recruited patients and pharmacists were surveyed, the pharmacist and the patients reported satisfaction, and there were higher continuation rates at 1 year compared to similar patients who received their prescription from a physician. One challenge that came out of this study was the payment for services. Those involved in the program were working to establish payment through one of the state's large insurers, but the logistics were not able to be worked out during the study period. It's important to also note that the study only looked at 26 participating pharmacies and a total of 214 patients. However, this study was very important because it showed that pharmacists were able to safely and effectively prescribe hormonal contraceptives according to a protocol, and that patients were willing to pay for these services. In recent years, we have seen several states propose and pass laws that give pharmacists the ability to prescribe contraceptives via a state protocol. The first states to do this were Oregon and California, but others have followed suit. We are seeing some differences in implementation, which we will discuss in the next few slides. The steps listed here describe the general requirements and process for pharmacist prescribing. Most states require some sort of training program, either within pharmacy school curriculum or through an ACPE-approved training program. Training varies and lasts anywhere from 1 to multiple hours. Most states require collecting standardized information using a self-screening risk assessment tool or questionnaire that is completed by the patient, an example of which is pictured in the next few slides. Pharmacists must then measure the patient's blood pressure. As we stated previously, the only physical requirement is this blood pressure measurement, and that's indicated in this chart from the CDC. Common among all current protocols is the requirement that certain information is collected from patients via a self-screening document. The exact form can vary, but this is an example of the form we will be using in lab. This form gathers information about medical history, conditions, medications, smoking history, pregnancy potential, and product preference. All of this information is necessary to consider when making a safe and effective decision for a patient seeking hormonal contraception. Some states require utilizing a specific algorithm for treatment, pictured on the left, while other states allow the pharmacist to assess the information more holistically while adhering to certain criteria for safety, including the United States Medical Eligibility Criteria document pictured on the right. We will not be using an algorithm for the cases we complete. However, the MEC will need to be utilized. Pharmacists then counsel the patient and document the process. In some states, the protocol requires pharmacists to alert the patient's primary care provider with the recommendation. Other states require that patients without a women's health provider are given a referral to a nearby practitioner. Patient eligibility is determined mostly based on age. Some states don't have any restrictions, but some limit new prescriptions to those women 18 and over. Typically, these states will allow the pharmacist to prescribe if the patient has previously been prescribed some sort of hormonal contraceptive product by a prescriber in the past. There are a variety of dosage forms of hormonal contraceptive products. Self-administered forms include oral tablets, both combined hormonal contraceptives and progestin-only types, transdermal patches, which are applied directly to the skin, the vaginal ring, which is inserted vaginally, and a depot injection, which can be self-administered. States may vary in what is allowed per protocol. For example, some states limit pharmacist prescribed options to the oral and transdermal forms. With so many choices, it's important to discuss the pros and cons of each available option with each patient in order to determine which product is the best fit for them. One thing I do want to point out is that the options a pharmacist can prescribe are not exhaustive of all contraceptive options. For some patients, the best option might be an IUD or an implant, something you can't provide as a pharmacist. It's important to talk to your patients about all their options. On the other hand, we don't want to delay access to contraception if we can provide a patient with a safe and appropriate option. Patients that come in seeking contraception from a pharmacy should be thoroughly educated, but the most important part is that we don't want them to leave without a product or a plan to work with another provider in order to prevent unintended pregnancies. For the activity we will be doing, students will be able to prescribe oral, transdermal, vaginal, or depot dosage forms. You will also be able to refer your patient to a provider. This option should only be used if it's not safe to use any of the products based on specific patient factors. Payment for service is another piece to consider as we see states passing legislation in this area. The products dispensed under these laws are covered based on the Affordable Care Act, which does not allow cost sharing for preventative care. However, payment for the pharmacist's time and consultation is not always guaranteed and depends on provider status in that state, as well as the way the law is written. For example, in Oregon, pharmacists are considered providers, and the law was written to reimburse the pharmacist's time at the rate of any other mid-level provider, such as a PA or nurse practitioner. Other states haven't specified this, though, or have limited payment for the pharmacist's time to an out-of-pocket payment by the patient for the consultation, which may limit which patients can take advantage of the service. Over-the-counter hormonal contraception is another possibility that is on the horizon. Several laws have been proposed in anticipation of this possibility, but have not yet been passed. Senate Bill 1438 was introduced in May of 2015 and was deemed the Allowing Greater Access to Safe and Effective Contraception Act. The bill was proposed to ease the transition of hormonal contraceptives to OTC status, which is actually not the pharmacy practice rule, but is instead an FDA decision. However, this bill would repeal the ability for health savings accounts and flexible spending accounts to be used on OTC products. The best example I have of this is what happened a few years ago with nasal sprays. Those of you who work in pharmacies may remember that when Flonase was granted OTC status, some insurance plans stopped paying for it because they did not cover OTC products. Many patients went from paying their lowest copay tier to having to pay $25 a bottle for the OTC version, which was the exact same thing. To counteract this potential cost barrier, a second bill was proposed in June of 2016. This Affordability is Access Act required that insurance companies cover OTC hormonal contraception. Basically, it maintains the spirit of the Affordable Care Act stance that there should be no cost sharing for preventive care, including contraception. Again, those last two are proposals that have not been passed yet. However, if they do, this would be a federal change and would apply to all states. Even if this law does pass federally, though, there are still some hoops for drug companies and the FDA to jump through before a product can be OTC. We do see a precedent in Plan B one step, though, so that might help. It's also important to realize that even though pharmacists will not be directly prescribing the product if it's OTC, community pharmacists will likely be one of the most important resources for patients who have questions or are choosing a product. So what's the big deal with prescribing? Is it really that much different than what pharmacists are already doing? Let's evaluate a few cases using the PPCP, or Pharmacist Patient Care process. We'll start with the dispensing scenario and then move on to a prescribing scenario. Julie's a regular patient at your pharmacy. She visits today to pick up a new prescription for levonorgestrel ethinyl estradiol birth control. Think about the process of dispensing this medication. What steps correlate to each part of the pharmacist patient care process? Julie's already a patient at your pharmacy, but if she were a new patient, you would need to collect some information to develop a patient profile in your dispensing software. For the assessment step, you would need to review her profile information and determine whether the product the prescriber chose is safe and effective. Is she on any interacting medications? Is the product safe based on her age? Does her insurance formulary cover the product? You can refer to the US MEC or a drug reference for more information in making your decision. Next comes the decision-making or plan. Based on your assessment, do you dispense the product, call the prescriber for more information, or recommend another product? Once you have verified that the product is correct, you must now implement the plan by counseling Julie on her new medication when she comes to pick it up. Its use, adverse events, monitoring parameters, and so on. Finally, you're a resource for any follow-up questions she might have. Alternative products if there's any adverse events, questions about missing doses, and evaluating future prescriptions for possible interactions. So Janet visits your pharmacy and is interested in having you prescribe her a contraceptive product. She's new to the area, isn't established with a physician, and doesn't have insurance yet. Prescribing has a few more steps, but the knowledge required to prescribe is not much different than the knowledge required to determine whether a product is appropriate for a patient and then provide patient counseling. During the first step, you'll need to collect information from the patient that is specifically relevant to contraceptive prescribing. Depending on the state you're practicing in, there may be a specific questionnaire that should be used to gather this information. You also need to measure Janet's blood pressure, ask about formulation preferences, and review her medication profile. In the next step, you need to consider all the information you have collected in order to work toward developing a plan. You will review the patient's responses, evaluate if there are any interacting drugs or conditions, and depending on the state, you may follow a specific algorithm, or you might just refer to the US MEC or a specific drug database or guidelines to guide your decision making. After you've evaluated the patient, it's time to develop your plan. Is it safe and appropriate to choose a hormonal contraceptive product for this patient? Or should Janet be referred to her prescriber for evaluation? After the product has been chosen, you will dispense the product and counsel Janet on the medication. Since Janet stated that she is not established with a physician, it is important to provide her with resources to find a new physician, including one who may be able to provide care at low or no cost because she stated she does not have insurance. Finally, the pharmacist will document the interaction so there's a file of the occurrence. If you're referring the patient to a provider, it's also important to explain why you are referring. If the patient is in need of immediate contraception, you will want to recommend over-the-counter options, such as condoms or other barrier methods to use until she gets an appointment. It's also a good idea to have a list of local providers who are welcoming new patients. If this is a new product start, you will likely want to follow up with Janet in a few weeks to evaluate her use of the product. Is she tolerating it? Does she require any adjustments? Is she taking it correctly? Depending on the answers to these questions, you may choose to adjust her medication. As she brings future medication prescriptions to your pharmacy, you will also review these drugs for interactions with the product she's using. I'm sure a lot of you are realizing that there might be challenges related to pharmacists prescribing these products. Some concerns that have been raised: the logistics of carrying out this prescribing in a busy pharmacy, providing a private and comfortable location to discuss the self-screening questionnaire with the patient, since this can be a sensitive topic, the pharmacist's comfort level with prescribing, the ethics of taking out the pharmacist as the double check to the doctor's decision, and the concern about women attending doctor's appointments to receive regular physical exams and screenings. Keep in mind that pharmacists who can provide this service are required to partake in specific continuing education activities before they're able to offer to prescribe in each of the states that allow it now. And also think about the opportunities of the pharmacist in helping ensure that women receive their recommended screenings. Having that patient interaction and providing medication counseling on the product opens up a great opportunity to discuss the importance of seeing a women's health provider and getting screened. Individuals may need that education piece and may also just need help seeking out a provider, which as a pharmacist you can definitely help them with. We will be simulating this process in workshop or lab in the coming week. You will be working in groups to review a patient's self-assessment questionnaire and interview a standardized patient to collect any additional information that you need. Once you have collected the information, you will work individually to develop a short patient care plan with justification for your option. For this assignment, we are giving you a broad formulary. Your options will include combined hormonal contraceptives in the form of a pill, patch, or vaginal ring, the progestin-only pill, or the depot medroxyprogesterone acetate injection, since these are all considered self-administered forms of contraception. You can also choose to refer, but for this assignment you should only be referring if there are no safe options available in that list for the patient. Make sure you're asking the patient about her preference for products as well. Patients may have strong opinions or past experiences that can help decide your decision making.